Okay, so welcome. You're here today, hopefully, because you are interested in learning about trichotillomania or hair pulling in children and adolescents. My name is Courtney Muller. I'm a staff social worker at the Baker Center at the Center for Effective Therapy. And today I'm going to be teaching you just a little bit about my experiences treating trichotillomania and how to identify it. I'll get into the agenda in a minute, but before we do, I just want to make sure everyone knows that this meeting is being recorded. The recording will actually be available on our website, or it'll be emailed to you if you registered for this event afterwards. So you can look for that. It won't have your faces in it, just my face and the slides. There are also some accompanying blog posts on this topic on our website, at the Baker Center website. One already up, another one going to be published next week. So if you're really interested in this, you can look there for some more information. As I begin speaking, if you have any questions that you want to just get down before you forget, you can go ahead and put them in the general chat, or if they feel a little more private, you can private message them to Alex Barawi. You'll see him there. He can gather those for the Q&A session at the end. So I'll talk for about 45 minutes, then we'll have about 15 minutes for Q&A if questions come up. All right, with that, let's get started. So that's me. So my plan for today, what I hope that you'll come away with, is an understanding of what is trichotillomania and other body-focused repetitive behaviors. These are a family of behaviors we'll learn more about, but mostly we'll be focusing on hair pulling, the trichotillomania. We'll talk about the origins and causes. I'll try to help develop an understanding of what is the internal experience of kids who are struggling with these behaviors, what are some effective treatments, and what caregivers can do to support their kids throughout this process. So I've used this term body-focused repetitive behaviors. This is just a phrase to describe a group of conditions that can cause someone to overgroom in a way that unintentionally causes harm to their body. So the goal is not to harm their body. It is this kind of compulsive habit that can affect various parts of the body. The two of the most common are hair pulling, the trichotillomania that we're here to focus on today, but also skin picking or excoriation is another really common one. Both of these actually have their own diagnostic code in the Diagnostic and Statistical Manual as mental health disorders. And then there are many other ways that are less common that still happen that this can manifest, like cracking fingers, biting of different parts of the body and skin, actually eating hair, thumb sucking, nose picking, teeth grinding. So you can see how there's so many different ways that we can have these repetitive habits around interacting with our body. So when someone is experiencing this, it's often an intense, uncontrollable urge. And then afterwards, it's followed by these feelings of pleasure or satisfaction. There's often a reward sensation that can reinforce the habit and make it more entrenched. So to get specific about trichotillomania, someone who is eligible for a diagnosis of trichotillomania will recurrently pull their hair. They will have had repeated unsuccessful attempts to stop and continue this behavior despite significant distress or an impact on their functioning. We also want to make sure that there's not another mental health issue or medical condition that's contributing to the behavior before we kind of determine that is what we're dealing with. This looks like trichotillomania. So there's so many different individualized ways that this can present, but typically there's a general trajectory where we see folks start by pulling hairs off of their scalp. Maybe it's the front, the back, the top of their head, along a part. And then sometimes folks move on to picking at their eyebrow hairs, or even their pubic region. And so that can be kind of feel very private, and people can become very secretive about some of these behaviors, especially as they get older and more aware and figure out that there's some taboo or shame around some of these behaviors. These behaviors can also be triggered by different sensory sensations. For some folks, it's in response to a sensory feeling. So maybe it is like an itch that then they go to touch and engage with it. Some folks, they're seeking a sensory experience. There's something about it that meets some sort of sensory need. And also emotional state can have an impact. Some self-soothing aspects of the behavior can play a role. When someone is having an episode of hair pulling, again, the theme of today, what you're going to hear me say again, it's so individualized, which is why treatment is really customized for this kind of treatment. So sometimes folks will pull 1 or 2 hairs and that's it. Sometimes a whole hour can go by of constant pulling. Sometimes people will pull 1 hair at a time and spend a lot of time with that 1 hair. Sometimes people are pulling fistfuls and not even aware it's happening. And so you really want to get a lot of information about that to inform your treatment. So some more information about trichotillomania. The typical onset period is between 11 and 15. And you know, that's for body-focused repetitive behaviors, that umbrella in general. You know, sometimes we see the hair pulling starting a little younger, with the skin picking starting a little older, perhaps because of puberty and acne. There's more imperfections and more triggers to want to pick at. Differences in the skin. In terms of gender, cisgender boys and girls have equal rates as children. In adults, we start to see a differentiation where more cis women are reporting, but that could be just a reporting difference and a difference in help-seeking behavior based on how folks are socialized based on gender. So it's unclear about that. So the prevalence that we do know about is, according to the research, 0.06% of the total population are believed to have met the criteria at some point in their lives. Now, this is something that can ebb and flow over your lifespan. So there might be a period of time where it's more intense, where it is causing distress or impairment, and a period of time where it's still present, but not quite meeting criteria. So at some point in people's lives, this is the number that we have evidence for, but it's believed that it's actually much higher because of some of the shame, lack of help seeking around it, and lack of knowledge that there's anything that can be done. So why would I share this private thing with a provider if I just think I'm the only one who does it and it's not something with effective treatments out there? And then the last thing here to know is that it's actually classified in the obsessive compulsive and related disorders section of the Diagnostic and Statistical Manual. So it's considered cousins with OCD. And this is because they have a lot of similarities. They're both involve repetitive behaviors. They both cause distress and impair someone's functioning, and they can co-occur. You know, trichotillomania and OCD are not the same thing, but they can both be present in the same individual. But there are some important differences. So OCD, the goal of the compulsive behavior is to mitigate the distress caused by an obsessive thought and prevent something bad from happening, whether it's a bad feeling or some superstitious idea about something bad happening in the world. With trichotillomania, the motivation is just this either an automatic habit or an escape from some emotional distress. With OCD, it's typically these compulsions are done in a state of awareness, like I'm intentionally doing this thing to avoid this outcome. Whereas with trichotillomania, it can be aware and intentional or completely unconscious, depending on the individual. And finally, for OCD, the experience of engaging in the compulsions is usually unpleasant and distressing. Whereas with trichotillomania, there's often a feeling of pleasure or satisfaction. So there's some real differences there in how these things present, although they are related. So where do they come from? The unsatisfying and short answer is there's not one clear single cause. But the limited research we do have does indicate that it's likely there is some inherited aspect, some shared brain structure and genetics that put someone in a position to be more or less predisposed to these body-focused repetitive behaviors. And so that alone, though, does not explain if we're going to see it manifested or not, right? It typically comes about through a complex and really individualized combination of having that genetic predisposition, encountering certain environmental stressors, what that person's particular emotional regulation skills are at the time that those stressors come up. Where are they developmentally? What is their personality and temperament? Distraction, like if they're, sometimes we see this more with kids with ADHD. If they're distracted and less aware, that unconscious pulling can be something that can be more likely to occur. So some common myths, people worry, oh, does my child have some underlying deeper issues or unresolved trauma that's causing this? And the research really doesn't support that. Trauma, just like any other stressor, can trigger it, but it does not create the behavior. Similarly, it's not a form of self-harm. The goal, right? We remember our definition, unintentional harm to the body. The goal is typically not to harm yourself. For folks struggling with this, it is to relieve stress or experience that gratification or other sensation, not to harm, punish, or distract from intolerable, overwhelming emotions, the way that we typically see self-harm being used for. And a final thing to note is that this is actually something that we see elsewhere in the animal kingdom. Scientists have observed birds overplucking their feathers and having bald areas, monkeys over-grooming each other. This is something that is not so far afield from other animal behaviors. It's not the norm, but it is something that we do see occur, and we are not exempt from. So it's really important for caregivers and therapists working with kids with trichotillomania to understand their internal experience. This can really help you build empathy and just get everyone focused on solutions that can address the problem with all the facts and feel like they're on the same team. Before you motivate someone to change a habit, you have to kind of understand, what is it offering them? What do they like about it, right? Before someone's going to leave something behind that they're used to doing, they're obviously doing it for a reason. So you want to get really curious about that. And you're not going to be able to help them develop an effective replacement behavior that's less harmful to the body, that meets those same needs, if you don't know what they are. So it's going to be much harder for them to stop. It can be seen as a super intentional act from the outside, but it's important to remember that people who are struggling with this don't typically have control over their actions in the moment. They might feel an urge to pull and feel like they don't have a choice. Even if they know, based on past family dynamics, that stopping the behavior would make the people around them feel better, they still might feel like they have to do it despite knowing that. So this can lead to some tense family dynamics. Family members can feel frustrated. Kids can pick up on that and feel guilty or helpless because they know how it's affecting people around them, and yet they still do it. So why pulling hair? Why is this something that is such a go-to for so many people? Well, our hair is always available. It's right there within reach wherever we go. We take our head with us. And so it's also plentiful. We're not going to run out of hair to pull unless things have progressed to a really extreme point where we only have a few patches of hair because we've pulled so much. Another reason pulling is so appealing is that the areas people typically pull from seem to be really rich in sensory nerve endings. So it can be very stimulating and therefore rewarding when you pull from a sensitive area and you feel a strong sensation. We all typically do more of the things that earn us rewards. And so this habit pattern is no different. You pull, it feels good, you're more likely to pull again. And then the more you practice it, the more automatic it becomes. You know, hair itself can also be super stimulating. It's interesting to touch and manipulate it. And people can find themselves doing all kinds of things with the hair that develop into their own personal, almost like stimulating sensory ritual. In terms of triggers, you know, these are the things that are going to make someone more likely to have a pulling episode. So it's super specific to the individual. So this is another area where we want to get really curious. I could be sitting down with a client who could tell me something I've actually never heard before, and I want to explore that and be really open to that. But there are some common triggers or situations where people are more likely to pull. So often this is during sedentary activities, lying in bed, reading, listening to a lecture in class, or riding in the car. It can also happen in certain locations like the bathroom, or when you're distracted talking on the phone or watching TV. And so for some people, they might be fully focused on what they're doing, looking in the mirror at the weird wiry hair that caught their attention and trying to perfect that. Or it might be completely unconscious and they don't even notice that they have pulled their hair until they look up from their iPad and there's 8 hairs scattered across the table. So the sensory triggers can be different for everyone as well, but some common ones are, like I said, feeling a hair with a slightly different texture, right? I can be resting my head on my hand at school listening, and I feel a little bump on my scalp, and I want to pick off that little scab or bit of dandruff and make it smooth. I can have one hair that feels a little bumpy, and I want to pull it off and look at it, right, and have that experience with it. So you really want to explore what is it that is appealing, that is offering that reward to this kid. It can be, there are some behaviors that kids can feel really embarrassed by that seem kind of out there maybe, or they worry other people will think. So it's always really powerful in session when I'm naming some of the things that I know people do with their hair. And sometimes kids will be like, whoa, people do that? And sometimes they'll say, oh, I didn't know anyone else did that. So that can be really helpful to normalize it and show, demonstrate some non-judgment by saying, some kids like to rub their hair on their skin after they pull it, or rub it on their face or lips. Some kids like to smell it, or chew or swallow it, or feel it rolling between their fingers. Getting really specific, because it's likely they have a very specific experience that they're doing. So opening the door for that. Trichotillomania is, when it's left untreated, the symptoms, like I said, may vary in intensity, but they will persist. And even with treatment, there's always the chance of lapse or even a full relapse of the symptoms. And there are a lot of barriers that we've been talking about to getting treatment. Some of the things that can happen, physical damage, you can have bald patches or thinning of the hair, can be hard to conceal. And over time, sometimes follicle damage can occur and hair loss can be permanent in some places. Medically, about 20% of people who pull their hair also swallow their hair. And that can result in some very serious medical conditions, including a GI blockage of a hair ball that can sometimes require surgical removal. And so you want to take immediate action if you suspect that your child is swallowing their hair, and talk to their doctor so that they can monitor that and make sure that there's nothing more dangerous happening. And then emotionally and socially, this can have a big impact. We've talked a little bit about the shame and secrecy that can be associated with this behavior. And that can lead to a lot of isolation. They're struggling with this alone. They can't talk to anyone about how it feels, and trying to hide, and the anxiety of being caught. It can all make for a really difficult emotional time. And some withdrawal from social activities, some anxiety. Oh, are they laughing at my joke, or did they just notice my hairline? Right? Just making already that age of, we're talking about 11 to 15 on average, already a difficult time socially in terms of self-esteem, just adding that extra complication. So what are the treatments? There are effective treatments, and the two major ones are habit reversal training and comprehensive behavioral treatment. HRT and COMB are their acronyms. Habit reversal training, the main idea is to try and anticipate, block, and replace those strongly learned behaviors that are resulting in some harm to the body. COMB is very similar. I find it helpful to incorporate a lot of aspects of COMB into the HRT, because it has some tools to help you dig deeper into understanding the stimulation-seeking behaviors and what their function is, and gets more in more depth about some of the awareness building pieces. Those can be just so helpful to validate what is the need being met and help you more effectively find good alternatives. I'll talk a little bit more about this bottom box, acceptance and commitment therapy and dialectical behavior therapy, in a minute. But basically, they address any emotional or cognitive aspects of the behavior that might be going on that could impede the progress with just HRT and COMB alone, if they were ignored. So sometimes that's necessary for folks who have some more overlapping challenges. And I don't have this on here, but people are often curious about medication. Sometimes it can be considered, but research is really limited. And the best practice, based on what we know right now, for kids and adolescents is to start with a cognitive-based therapy approach. And all of these are under the umbrella of cognitive behavioral therapies. So to get more into habit reversal training, it has 4 stages. We start with awareness training, where we're really also wanting to do a lot of psychoeducation, build a strong rapport so that they can openly share, and we have the data we need to help them plan, and reduce that shame and stigma as much as possible. We talk with kids about how this is going to be really collaborative. It's going to take time and require a lot of trial and error. We educate them about what is a habit, right? It's not so helpful, I find, to say that there are bad habits and good habits. Instead, I try to frame it as, habits are just actions you do over and over until they become automatic. And if a habit is causing problems for you, it's possible to change it through hard work and by paying attention, staying alert. So just, is this habit working for you? No? Okay, no biggie. We'll just try to do a different habit. Oops, where are we? Yeah. So to get more into the first step of building awareness, this is where I bring in a tool from Comb, and it's called the SCAMP assessment. And this stands for sensory, cognitive, affective, or feelings and emotions, motor, and place. And this is just a helpful framework for having kids sit down and really reflect on all the different ways that this habit might find its way in, all the different clues that an urge is either present or times when it might be likely to pop up, so that we're not trying to fight back against a sneak attack. We're a little bit more prepared and ready with our tools when that urge comes. So sensory asks things like, what does it feel like when you pull a hair? Or even beforehand, what are the physical sensations that lead to you having the urge to pull? How does it feel after? Getting really tactile and descriptive. Cognitive explores the thoughts around the process. What do you think right before you pull? Capturing those thoughts. What do you think after or during? Maybe a before thought is, I'll just pull one. I haven't pulled all day. I've been so good. I'm going to just give myself a little treat. Or afterwards, you did it again. You're no good, right? Some shaming thoughts. We want to identify those thoughts so that we can address any distortions and just really be on the lookout. So that those are little alarms. And we know how to recognize what precedes or happens during an episode. The feelings affective question, what are you usually feeling before, during, and after, right? I'm usually feeling bored, or I'm usually feeling anxious, and I do it to soothe myself. We want to help them really tap into that so that times when they might be bored, we're going in ready. If they're feeling a lot of guilt and shame afterwards, we want to find ways to help mitigate that, because those are feelings that we run away from. And if we're trying to escape the distress of those feelings, we're not paying attention because we're trying to just not think about that thing that makes us feel that way. And we do need to pay attention for this to work. Motor is, what is our body physically doing? Does it happen when we're bent over putting our shoes on and we see that little ingrown hair on our shin? Or does it happen when we are sleeping at night and our hands are under our head and we feel our hairs? So the physical movements of how your body is responding and what precedes it. And then locations, place. Well, I normally notice that I pull hair when I'm watching television on the couch, or it's always in the bathroom, right, with the door closed. We want to identify those danger zones where things might creep up and be more likely to happen. You want to adjust this process for the developmental ability, insight, and age of the kid. You got to be a little bit creative depending on what their skills are. But usually you can get a lot of good information kind of using these general buckets to approach. And sometimes just the awareness building is enough for someone to start decreasing the frequency with which that behavior is occurring, just by kind of waking up and being like, oh, look what I'm doing. The next step is to create a competing response. So this is going to be the new habit that replaces the pulling behavior. So now we've got all our data from our awareness building, and we can use that to find a new behavior that's going to meet some of the same needs And also importantly, make it impossible to engage in the old behavior. So they compete with each other, right? It's not just a different response. It's one that actively, because I'm doing this, I can't do this old thing. It should also be something you can do in any situation, just like we take our hair with us everywhere we go. It needs to be something that's always accessible. If it's a fancy fidget toy, but we're not allowed to have it out in class, that's not going to be a very effective competing response because it's not accessible. And then finally, you want something that is not noticeable to others, especially with like teens. They're not going to want to be calling attention to themselves. So you don't want a competing response that's going to draw a lot of eyes or be disruptive in different environments. What you're going to need to do is practice this a lot. You've had so much time practicing the hair pulling behavior. And so you want to set expectations that you're not just going to be able to flip a switch and do one instead of the other, but every time you practice this instead of the hair pulling, you're weakening that old habit by denying it the chance for practice, and you're strengthening the new one. So some examples of some competing responses: clenching your fists when you have the urge. You can't pull my hair if my fists are clenched. Sitting on your hands, having that feeling of pressure might provide that other sensory experience that you're looking for, while also keeping your hands well away from your head. Putting your hands into your pockets, like this little cartoon here is doing. Now, for some folks, they have some things they need extra help before being able to engage in the competing response. So for folks who are more unconscious in their pulling, they're not going to be as likely, at least initially, to notice those signs that they are about to pull and sit on their hands. They're going to need some extra help to weaken the old behavior by just completely blocking access to the pulling. So this can look like wearing a hat so that when they're bored in class and they're resting their hand on their head, they're touching wool, not hair, and they're not getting that trigger. Watching TV with mittens on, you know, when they're totally distracted and not paying attention, and they find their hands on their head, they're kind of noticing it's not working, and then they're conscious, and then they can use their competing response. Just putting that extra barrier between them and the behavior. Someone picks their cuticle skin, thinking of the skin picking sister challenge, wrapping some Band-Aids so that they're not seeing that, and there's just another layer of defense. That's a temporary solution. It's not a long-term solution. It needs to be combined with practicing a real competing response, but it can help buy time for folks who are just a little bit less aware. You also might need to just take some steps to reduce triggers. So this can look like using a timer in the bathroom if you've noticed that you tend to spend 40 minutes in the bathroom engaging in this behavior. If you only do it in private, keeping the bedroom door open if it means you're less likely to engage in it because you think someone might walk by. Removing objects that you might use to pull, like keeping tweezers away. Things like that can really help just avoid those danger zone situations and strengthen the possibility of success. Motivation is a really important piece here because, as I've been alluding to, there's a ton of trial and error. It can take a long time, and there'll be long stretches of data gathering and finding out what doesn't work. You know, I think we've all heard that quote, that Edison, I don't even know if it's a real Edison quote, but I have not failed. I've just found 10,000 ways that won't work with the light bulb. That's a little bit the feeling of habit reversal training. You might try 6 different competing response things until you find the one that actually works for this kid in this moment. So once you find one, you put in the work, you put in the hours to build that habit and strengthen it. Another challenge is that by the time folks get into treatment, caregivers and kids are often like really eager to see an immediate reduction. But you really have to spend time in those early stages, building trust with the therapist so you can get accurate information, building up your awareness, and exploring replacement behaviors. That's going to be essential to your long-term success. And so because the finish line is so far down, if we're thinking of the finish line as like complete extinction of the pulling behavior, we want to really celebrate those small successes along the way. If a kid says, I noticed an urge right before I pulled, and that's a kid who's typically been pretty unconscious in their pulling, you're celebrating that growth and awareness. Or if someone says, I notice I tend to pull a lot when I'm watching TV. Fantastic. Hair pulling days are numbered. We're really catching up. We're catching on to all their tricks. You want to create a story of success and momentum because it is a long road. Some kids are super motivated and eager to problem solve and get those tools. Others kind of couldn't care less. They just enjoy the sensation and the stimulation, and it's not a problem to them that they have a bald spot. They're not worried or bothered about it. And so for these kids, rewards, external rewards can be really helpful. You want to be thoughtful about what you're rewarding. You can reward things like completing your therapy tracking sheets or attempting a competing response, even if you ended up pulling. Because again, those small successes, if we wait and only reward if they don't pull for a month, they're going to lose motivation, they're going to trip up, and they're going to start to feel like unsuccessful. Sometimes, you can reward for not pulling, but it can get a little tricky. Sometimes that can accidentally encourage a return to kind of secrecy. If the kid's like, I want the prize, and so I'll say I didn't pull, right? And it can just make it harder to get accurate data that can help us see what's going on. So that's kind of case by case. So these supplemental treatments I was mentioning before, acceptance and commitment therapy is all about promoting acceptance and tolerance for all different kinds of things. But when applied to this, the urge to pick or pull, without the need to kind of act to reduce or eliminate that urge, right? The goal is not to avoid the urge. The goal is to say, yeah, look at me having an urge. I can accept that I can feel something and not need to act on it. And it can be very freeing. And because we tend to try to eliminate unpleasant experiences as well, ACT can be really helpful with its mindfulness basis to help us learn to experience and accept negative internal emotions without having that immediate reflex to reduce or modify or eliminate that negative emotion and just sit with it. So when we have the ability to do that, if there's a strong emotional component to someone's pulling, those can be really helpful strategies. And DBT similarly focuses on the mindfulness, the emotion identification, regulation, and distress tolerance. So if hair pulling is the primary tool someone is using for those things, we can give them some other tools that can then open up a little more flexibility, a little more breathing room to resist that particular habit. And then finally, we really want to prepare folks who are leaving treatment to have ongoing success. And part of that is really normalizing for kids and caregivers the possibility of a recurrence. A smaller recurrence, we think of it as just a lapse, right? That's probably going to happen. And now the family has all the skills they need to kind of nip it in the bud, try to get back on track with the competing response habit. But sometimes it can balloon bigger, and it can be something that you need additional support to get under control again in terms of like a full relapse. So helping folks prepare in advance. Well, what's the difference? How will I tell between just a lapse that I can kind of handle on my own and a full relapse where I need to kind of go and get support? The earlier, the better, so the habit doesn't have that much time to get re-strengthened, re-entrenched. And so those are some conversations you want to have too, because again, shame and guilt, if they think that they're supposed to be cured forever now, might prevent help-seeking behavior early when it can be most helpful. So that, I think, is everything I have to offer on this topic. I'll hand it all over to you guys for any questions you might have.
I was curious if you would be comfortable answering if we're treating any patients with this. I had a few questions about some of my current approaches with this particular patient. I don't know if you have time for that.
Yeah, can you think of a specific like approach that you were wondering about the effectiveness of?
Sure. I think I've been working with a patient who's 14 for almost 2 years, and one of the difficulties is the culture consideration. Her parent is from a different country, and he is really struggling to understand trichotillomania and how it intersects with mental health. And have had sessions with an interpreter with dad, and then I referred them to psychopharmacy for possible med management, and had another with a Spanish speaking interpreter provider, and then I had another session. So we're on about our fourth time. Dad is continuing still shaming the child and really is struggling to understand that she has no control over this. And the child, for example, will has been wearing a beanie for almost most of her life to kind of prevent herself from pulling. And
Yeah,
he's just really, really struggling, and it's perpetuating the shame. And so lots of
yeah.
things of family humiliation and talk about this. So if there's any
So generally,
way,
just, you know, I won't go into like a specific case thing, but a general theme that sounds like it might be helpful is when communicating with caregivers, because this can trigger really strong emotions in caregivers, right? Like your child, like, how does it reflect on me that my child is walking around with a big bald patch on their head? Or, my own hopes for my child's future and the ways I want to protect them, right? It can just kind of also just be irritating or gross sometimes for people, right? And those are valid human responses to this. And so often, you know, if our approach is being informed by that emotion, what I'll ask caregivers to do is reflect on, first, I'll validate it and be like, totally understand where that's coming from. And then explore, is it working? Right? There's obviously this urgency to see change. We want this to change as fast as possible. How long have you been trying this way? What progress has that given you? Do we need to find a different path in order to get there sooner? Even if this emotionally feels like the most direct path, for the past year, has it actually gotten us anywhere? And just ask them to look at their data themselves rather than you trying to convince them what the research shows. They have their own research in their family history that they can reflect on. That's going to be a lot more valid to them than anything you can say happened in a study somewhere with people they don't know. And so you can validate like the cultural pieces and the values and just say, well, if our value is that this shouldn't be happening, take a leap of faith, take a risk with me, and try this way to get to that same end goal.
thank you. Yeah, I think that the hard part is like looking back at the family history when it's such a new exposure to even know the word mental health. So like trying to find
Just looking at like how often has the data been going on, or like the pulling behavior, the things that they can see. Yeah. Any other questions just about trick in general or treatment?
I have a
Oh, I
question
see a data
around,
sharing. Oh, go
oh,
ahead.
just wondering, and I know that this is likely, your answer is likely to involve, it being individualized for the patient, but like wondering if there's co-occurring challenges going on, and particularly trauma and a history of trauma, just kind of like the order of operations around what to treat first and whether or not treating some of those co-occurring challenges, particularly if the picking is a little bit more intentional, might, reduce the picking, or if everyone sort of needs a focused course of HR to see change.
Yeah, it, as you intuited, is going to be so individualized. But we know that like trauma focused CBT does involve a lot of relaxation skills, emotion identification and modulation, and like some like so there are aspects you'd want to assess what is most impairing and what is most accessible in terms of the treatment. You really need motivation for HRT to work best. And so if someone has no motivation to work on their hair pulling, but wants to address their trauma, like that would inform kind of your decisions. But you start where you're able to actually start, and then and then reassess what is feeling helpful or what is necessary. What do things look like once one thing has been addressed, and what's still necessary or not. I see a question in the chat about data sharing. Does this mean like tools that are used to track use of competing response, where urges are happening, all that kind of thing in the kind of awareness building and exploring?
Right. Yeah, sorry, I was typing too fast. I meant to put data collecting.
Oh, okay, great.
Sharing.
Yeah. I customize this again for the kid, their developmental stage, right? Some kids like older teens like a really detailed tracker where they can say, oh, my urge was this number out of 10 and it happened in this place and these were the thoughts, and they want all of it there. And some kids want a sticker that shows I tried my competing response today. And so you really just kind of feel something out, try to make it based on like, I'll put unicorns around the border so they want to look at it. If they're super into unicorns, finding ways to just make it feel personalized and exciting. And, often there's a caregiver element of supporting them in remembering and praising and reinforcing the use of the tracker. Yeah.
Thanks.
Yeah.
Can I ask a quick question? First off, thank you so much for this presentation. This is really helpful. But just a question about, I worked with a kiddo a couple of years ago who was 8, and he had ADHD, and it wasn't necessarily trichotillomania, it was more like the skin picking. But just wondering about what you do when caregiver motivation is so high, right? Like this was a few years ago, so it was like during COVID, and the open sores were really, really distressing to mom. But kiddo was 8 and just didn't really care too much, and hadn't experienced any of the like social repercussions also. So his motivation was pretty low. But mom would come into session and just be really distressed about how she wants this fixed ASAP. And so you spoke about it a little bit, just like, how to motivate kids with reward charts and things like that. But I just wonder, like, if it doesn't really bother them in the first place, like what you've done to kind of get their buy-in a little bit more.
Yeah, it's really tricky, especially if there's such a mismatch in the family in terms of motivation. So I'll typically try to approach it from both sides. I'll try to provide psychoeducation to the caregiver and help, while I'm not the caregiver's therapist, offer some general pointing in the right direction for something that might support their own emotional regulation, and kind of informing about how that might benefit treatment if they're having less of a response, because caregiver responses can sometimes accidentally be reinforcing as well, right? Oh, every time I do this, my busy parent turns and looks and says something to me, even if it ends up being a negative interaction. Negative attention is better than no attention. So that can add an extra layer on top of the behavior that might already have its own internal intrinsic reward of the sensory benefit. There can be a family dynamic that can grow up around it. So providing some education to parents on how you can balance helpfully reminding children to use their tools without giving too much of an emotional or juicy response to seeing the behaviors, how that can actually, again, be that other path that gets us where we want to go faster, even if it seems like a longer road. What was your other question? Oh, and then with kids and rewards, yeah, finding ways to give tangible rewards that work for what they're currently able to do, right? That they're having some success, but they're stretching themselves to try more. Sometimes even just like rewarding kids for doing drills. I'll do drills with them where we're like talking and they're drawing and they're telling me about what they're drawing and I'm talking to them normally, and then I'll just say, and the urge appears or something, and they have to like notice and sit on their hands, and just building that habit in a fun way can sometimes support them in using it successfully in the moment. But it's definitely tricky when there's really low motivation from a kid. Sometimes I'll also give kids some psychoeducation, like maybe they don't care if they are missing one of their eyebrows right now, but I sometimes tell kids about follicle damage, and that, it might not always grow back. And, let them kind of imagine if, as an 8-year-old, I don't care. When I'm 20, do I want 2 full eyebrows? Maybe I do. So sometimes that can support them in just expanding their perspective. Not in like a scare them way, but just offering
Yeah,
them.
that's
Yeah.
really helpful. Thank you.
Yeah. I see a question about assessment tools to evaluate severity. I don't have anything super formalized. Like, some parents will sometimes take photos, right, of an area to also encourage motivation. Like, look how much that's filled in, or okay, you say you're not pulling, but we're seeing it get bigger and bigger, the bald spot here. I see, someone has some good resources from Mass General, so that's great. But yeah, like you can also sometimes just someone comes in and their lips are bleeding or their eyebrow is way patchier than it was last week. Or you're just hearing about impairment, or it's a teenager who's reporting like a lot of distress and really like mental health impact from this behavior. I see one question here in the chat about research on long-term trajectories and aging out of it. If it's to the level where it's like meeting criteria in terms of the distress and impairment, these tools are probably going to be helpful. It's like I said, it can ebb and flow. So even without treatment, it might go in and out of being like clinically impairing, but it's unlikely to be something that significantly reduces without having some intervention. Yeah. I see a question about shaving heads. That would be an example of a more like extreme version of that interference model, right? I'm trying to buy myself some time so that I'm not as tempted. I don't have as much access to the ability to pull. And in the meantime, you practice that competing response and try to give that habit kind of a head start to gain some ground. So that's what those interference strategies do. And yeah, there's tons of different creative ones you can come up with, and it can sometimes be fun for kids to come up with them. And oftentimes my clients come up with things I wouldn't have thought of that work really well for their specific situation. So you really want to brainstorm together. Any other questions while we're all still here together? All right. Well, like I said, feel free to check out the additional resources on our website, and that are going to be, the recording of this will be emailed out to you. And I think we also put it on our YouTube, if I'm correct about that. Yes, I see a nod. So you can always access it there later, as well as recorded videos of all our other presentations. We do one every month on a different topic. But thank you for coming to this one today. Great talking with you all.